In this VAP, we will discuss the approach to dementia. Dementia is a common neurological disorder that particularly affects the elderly. The prevalence of dementia and cognitive disorders is expected to rise in countries with an aging population such as Singapore and the US. Hence, it is important to understand how to assess and manage patients presenting with dementia. At the end of this VAP, you should be able to define dementia, list its cause and distinguishing features, describe the history and physical examination for a patient presenting with dementia, name the appropriate diagnostic test, and describe the management of demented patients. Dementia is characterized by a deterioration of function in multiple cognitive areas in an individual who had previously possessed a normal cognition with little or no disturbance of perception or consciousness. Dementia is defined when a cognitive decline interferes with work and social activities of the patient. Bear in mind that cognitive dysfunction manifests along a continuum ranging from mild cognitive impairment to dementia. At the milder end of the spectrum is mild cognitive impairment or MCI. The hallmark of MCI is presence of cognitive decline that does not fulfill the criteria of dementia. The daily activities of these patients are not impaired. Only one cognitive domain may be involved. It is crucial that clinicians are able to identify these earliest stages of cognitive impairment. Patients with MCI progress to dementia with higher rate. They thus should be monitored closely for deterioration. Important causes of dementia include Alzheimer's disease and vascular dementia. Mixed dementia is usually a combination of Alzheimer's disease and vascular dementia. Other causes of dementia are frontotemporal dementia or FTD, dementia with Lewy bodies, and normal pressure hydrocephalus. Differential diagnoses for rapidly progressive dementia include Creutzfeldt-Jakob disease or CJD, subacute spongiform encephalopathy or SSPE, HIV, hypothyroidism, and SLE-related dementia. It is important to know the reversible causes of dementia. These should be considered in all patients presenting with cognitive impairment, as treatment can ameliorate the condition. The reversible causes of dementia include hydrocephalus, thyroid disease, vitamin B12 deficiency, chronic meningitis, and neurosyphilis. Depression with pseudo-dementia must also be ruled out in patients reporting problems with cognition. This chart shows distinguishing clinical features for the various common causes of dementia. In patients with Alzheimer's disease, absence of motor, coordination, and gait deficits are major distinguishing features. Memory impairment and language dysfunction are typical. MRI brain may show hippocampal atrophy. In patients with vascular dementia, the disease course is stepwise or progressive. Patients usually have vascular risk factors or previous vascular events. On physical examination, there may be neurological deficits. In patients with frontotemporal dementia, early behavioral abnormalities and obsessive-compulsive features will be noted. The trait of symptoms and signs of normal pressure hydrocephalus is dementia, ataxia, and urinary incontinence. Imaging will show ventricular enlargement out of proportion to brain atrophy. CJD should be suspected when there is rapidly progressive dementia associated with myoclonus. MRI of patients with CJD may show abnormalities in the basal ganglia. EEG may show periodic discharges. Patients with dementia with Lewy body classically present with vivid visual hallucinations and fluctuating cognition. Extrapyramidal features such as tremors or bradykinesia predate or follow onset of dementia within 1 year. It is important to get history from relatives or caregivers. Short-term memory is often affected early in the course of dementia, and patients may present with difficulty remembering names, misplacing their personal belongings, or for being repetitive. Long-term memory is often relatively preserved in the early stages of dementia. Problems with visual spatial function may manifest as difficulty finding one's way, even in familiar environments. As the dementia progresses, most patients will have word-finding difficulty. Executive functions such as planning, organization, and judgment will be slowly impaired. It is important to establish patients' functional impairment. We should know what patients can and cannot do in their daily lives. Safety issues should be addressed, such as the ability of carrying out routine tasks like cooking and driving safely without the risk of trauma or accidents. For example, when a patient prepares a meal, has he or she ever left the stove turned on? Has the patient gotten lost while driving? Or has the patient been involved in any avoidable accidents or traffic violations? In the history, one should attempt to ascertain the etiology of dementia and should include history of vascular disease and risk factors, heat injury, toxic exposure, symptoms of infection or exposure to diseases such as tuberculosis, psychiatric history such as depression, symptoms of depression, medications, systemic illnesses, and alcohol or tobacco use. We should perform a full neurological examination of patients who present with cognitive impairment. We should look for any neurological deficits that suggest cerebral vascular events, which may point to vascular dementia. Extrapyramidal signs like tremor or bradykinesia may be detected in patients with dementia with Lewy body. Cognitive screening tests like Mini-Mental State Examination or MMSE and the Montreal Cognitive Assessment or MoCA can be easily performed in the clinic or bedside. The MMSE and MoCA are cognitive evaluations which are quick and require little training to administer. Full neuropsychological testing is conducted by trained psychologists. This assesses the various domains of cognition and measures the degree of cognitive impairment in each domain. The assessment will help to differentiate subcortical and cortical features of cognitive impairment. Depression or other emotional conditions may also be detected during the test. Important blood investigations include vitamin B12 and folate levels, thyroid function testing, syphilis screening, renal and liver panels. Brain imaging is important to rule out stroke, mass lesions, and hydrocephalus. Electroencephalography or EEG is useful when prior diseases are suspected. A lumbar puncture or LP can be done to look for protein 1433 in prion diseases and to rule out chronic meningitis. In the management of a patient presenting with dementia, it is important to rule out and treat reversible causes such as hypothyroidism, B12 deficiency, and neurosyphilis. A multidisciplinary team-based approach is important to ensure that the care of patients with dementia is holistic and coordinated. Non-pharmacological management is crucial. This includes support groups and services, as well as education for the patient and family. Cholinesterase inhibitors and NMDA receptor antagonists are two classes of disease-modifying drugs for dementia. Antidepressants and antipsychotics may be prescribed for management of mood and behavioral issues. This comes to the end of this presentation on dementia. Thank you for your attention.